Welcome to Quality, where we are exploring quality in emergency care. This is your host, Arjun Venkatesh, and today we have our next episode in our substance use disorder series as part of the ASAP Emergency Quality Network. I'm joined by Dr. Kate Hawk from Yale, who co-leads this initiative in substance use disorders, and we have a special guest, Dr. Matt Salzman, who is an emergency physician, a toxicologist, and medical director of the Consult Liaison Addiction Service at Cooper Medical School in Camden, New Jersey. Today, we're talking about something that's new, something you haven't seen a lot of research about, but something that you're hearing a lot about, both in the news as well as the clinical space, and that's xylazine. I'm going to kick it off, Matt, with a question that's pretty simple for most of our listeners, which is, what is xylazine and why is everybody talking about it?
Hey, thanks for having me today. And it's a great question. Xylazine is a large animal sedative. It does not have any approved use in humans, studied very briefly in humans, but found to be, far too potent. It's an alpha-2 agonist, similar to clonidine and dexmedetomidine. And it is not new as a misused substance. Goes back over 10 years. But has recently emerged in high rates in the fentanyl and highly potent synthetic opioid supply in the Philadelphia area, the Camden area, and has spread across the United States. It's getting a lot of discussion. You can see reports in the lay press, including the New York Times, a lot of discussion around the wounds that are really horrible and associated with xylazine use. And how hard it really is to treat. It's really emerged and we're seeing a lot of it and warrants some close discussion.
Yeah, no, it sounds like a lot of people are both talking about it. I know there's a lot of questions around sort of testing for it, these wounds and overdoses. Kate, you were recently an author on a piece that was describing these xylazine overdoses and reviewed a lot of the literature that was out there. Was there anything that really stuck out to you that emergency physicians should be thinking about?
Well, I think one of the things that is so challenging about this is I think we're still trying to understand how this fits together with, how this acts, in the body on its own and how it actually changes the frequency with which people use fentanyl, the routes, and the potency or quantity of fentanyl that is in the supply that they're using. So it's not, at least my understanding of the literature where we're at right now is it's still not totally clear the role that it is playing in sort of how people are using opioids and how that actually affects overdoses. I'd love for you to shed any light on that, Matt, or if there's a simple way that you can help break it down, I would love to hear it.
I wish there were a simple explanation. What I can tell you is based on my personal clinical experience and also what's been reported a little bit in the literature is that one is that xylazine is not really sought out, generally speaking. I think one study found that like about 75% of respondents actually didn't want it, but they couldn't find fentanyl or opioids that didn't have it. And right now, the most recent estimates are like 96% of the fentanyl that is being tested in the Philadelphia area is positive for xylazine, about 60% in the Camden area, from what I understand. And then we actually, in our outpatient clinic, we test for fentanyl. And when our patients are positive for fentanyl, we have reflex testing for xylazine, and 90% of our patients that are positive for fentanyl are also positive for xylazine. So it's there. The why, like, we never really know why, right? Adulteration in the street supply is, again, also not new. This goes back decades. And some people say that this is like possibly the best argument for safe supply, right? For our patients who do use drugs. Some of the speculation is that it's added because fentanyl has such a short duration of action and rapid onset of action that xylazine, the expression is, gives it legs, meaning it extends the duration of effect. but really leads to prolonged sedation and downtime. And patients report that when they wake up, they feel terribly anxious and that the withdrawal is very different from opioid withdrawal. And that leads to return to use. And some people even reporting that while they don't seek it out really, they feel like once they have that withdrawal state, they have no choice but to go looking for fentanyl with adulterated, with xylazine adulteration. So it gets, I think, again, I wish there were a simple explanation for all this. I'm just not sure that there is one. And it's pretty complicated. But again, adulteration in the street supply isn't new.
I want to get to withdrawal in a second, but one of the things you mentioned that was interesting up front is the amount of testing you're all doing. It sounds like there's a lot of testing happening in the Philadelphia area. There's this reflex testing you're doing. Help straight that out for the average community emergency clinician. Is there a readily available test? And even if it was available, like how would it affect our clinical decision making? Should we be going to our hospital administrators and asking for it if we don't have it? Or is this more a clinical type of challenge?
I think from the emergency department standpoint, I don't know that there's a lot of utility for routine screening for xylazine. I think, we could reasonably make clinical determination if a patient's got kind of prolonged sedation, bradycardia, hypotension, they likely, and in the setting of an opioid toxidrome, it's likely that the patient has used a synthetic opioid with xylazine in it. And I'm not sure that adding the xylazine testing really adds a whole lot here. I think for from a surveillance standpoint, there might be utility kind of on a population level. And then in terms of drug testing itself, one thing that I just want to issue a little bit of caution about is that in New Jersey, xylazine test strips were only recently legalized. So for a long time, they were considered drug paraphernalia, quote unquote. And if you were caught with xylazine test strips, that's, a potential, legal offense and you could go to jail. New Jersey has subsequently said xylazine test strips are not paraphernalia. And so we can now distribute them and our patients can use them. But you need to check on a state-by-state kind of basis to see what is considered legal or not legal in your state.
Matt, I just have a follow-up question to that. And that presumably also applies to fentanyl test strips in your state at the time? So it was all...
fentanyl test strips have actually been permitted for a while. Xylazine test strips only recently permitted.
That is fascinating. Something I did not know before. But you can imagine, right? Like particularly if word gets around and you hear about it, even if you're not in Jersey and you hear about it in Jersey, these are the kinds of things that can totally get in the way for patients being able to access tools that can help with harm reduction, improve safety. That's pretty scary, but probably something folks should look up, know for your state, be able to answer that question if a patient asks about it, and be able to provide reassurance to a patient if you're hopefully in a state where it's okay.
So Matt, I want to follow up on something that you had mentioned earlier, which is, one of the challenges with, caring for folks who, have opioid use disorders and have frequent exposure to xylazine is trying to suss out what the withdrawal syndrome looks like. And if you have someone who, you are treating their opioid withdrawal with buprenorphine or methadone, sort of any strategies you may have, either anecdotally or just based on your experience as a toxicologist, would be really helpful for folks trying to sort this out.
Yeah, it's a great question. And I think it's a really important one. I think I should preface it by saying that there is debate as to whether or not xylazine withdrawal is actually a thing. And there is one paper that suggests that maybe it is, maybe it isn't. And our some colleagues and friends over at the University of Pennsylvania have some data as to try to figure out whether or not xylazine withdrawal is really a unique phenomenon. I will tell you that my patients report that it is definitely a thing. And they report a lot of anxiety, and generally not feeling well. They say it lasts for about 3 days after last use. And so while when I'm seeing patients in the hospital, we are initiating buprenorphine, we're initiating methadone. In terms of dealing with xylazine withdrawal, again, because it's a lot of anxiety, while I don't really like using a lot of benzodiazepines, in the setting of withdrawal, I will use a benzodiazepine for about 3 days. I try not to go any longer than that. I will also use other alpha-2 agonists like clonidine, and also have used tizanidine. And speaking with some other folks, they will sometimes use those medications in combination. I try to rely on one or the other and really just seeing what is more helpful to the patient. If I'm trying clonidine and they're still not feeling great, I might switch to tizanidine. We've also used intranasal dexmedetomidine in the emergency department a couple of times with some really good reduction in COW scores. Now, granted, again, I think there's a little bit of a confounder that the patient also looked like they were having opioid withdrawal, but they were also endorsing a lot of symptoms that I think we could attribute to xylazine withdrawal. One dose of intranasal dexmedetomidine really reduced their COW scores pretty dramatically without any adverse effect on their hemodynamics or sensorum.
Matt, and do all those, like any of those strategies, work alongside bupe? And the reason I ask is, most of the sites in Equal are really focused on getting programs up and going within their ED to improve treatment for opioid use disorder. And so that's really trying to encourage their clinicians to identify OUD, encourage people after an overdose to get in treatment, and to write that first script for bupe. Yep. How does, does this, I want to make sure that we don't overcomplicate it for folks. And then, we add yet another sort of clinical challenge, which makes it harder for folks to sort of join the bandwagon, I could say, in some ways.
Yeah, it's a great point. And I think, like, from the emergency department standpoint, I mean, there are always challenges, right? And I think trying to manage xylazine withdrawal on the outpatient side can be really difficult. And in our clinic, we try a whole bunch of things. I don't really have any data to share with you about what success looks like, but we try. And I think we're all pretty comfortable with using medications like clonidine and tizanidine for opioid withdrawal in general. So if we're initiating medication for opioid use disorder, because most of our patients who are getting xylazine are getting it alongside of highly potent synthetic opioids, starting bupe or starting methadone in the emergency department and linkage to care is really important. I think the challenges with buprenorphine initiation are really more so around fentanyl and fentanyl analogs, and how we are understanding more and more that buprenorphine initiation with concerns of precipitated withdrawal is just really changing the landscape, I think, of buprenorphine initiation, and then also trying to figure out what the right dose is for patients, right? And I know this is a little bit more towards bupe than it is towards xylazine, but in the setting of highly potent synthetic opioids, like, we were taught 16 milligrams is your total daily dose of buprenorphine, and that should be fine. But that's all based on when heroin was actually heroin and not fentanyl and fentanyl analogs. And I'll tell you, we're pushing our doses of up to 24 to 32 milligrams total daily dose, and then using a lot of microinductions to try to get bupe into patients while minimizing precipitated withdrawal. And that's like part of the challenge along with this. And then the adjunctive medications can be helpful. And hopefully, again, as emergency medicine physicians and providers, we're comfortable with, clonidine as adjunctive treatment and tizanidine as adjunctive treatment. I don't know that I could really advocate for an emergency medicine provider sending a patient home with like 3 days of clonazepam along with bupe and all the other medications they're getting. My lens is a little different because I tend to do more of this on the inpatient side in the hospital. So I don't want to, minimize how hard this can be for emergency medicine physicians, but I think it's doable.
So I wanted to follow up, just in case, I think we're going to have a broad spectrum of folks who are listening to this. And I feel like sort of dosing around clonidine is always something that people are surprised about, depending on sort of their experience. So I would love to hear your approach, around clonidine dosing and, in addition with buprenorphine in these patients.
Yeah, I think I'll usually start off with 0.1 milligram 3 times a day. And then again, it depends on the clinical context. If I'm sending somebody home from the emergency department, I'm probably going to lean on the lower dose because I do worry about hemodynamic effects when we're titrating up higher doses of clonidine. But, if we're seeing somebody frequently and can get them up to 0.3 milligrams 3 times a day, I'll try to push that dose. I'm not sure that I'd ever go higher than that. I feel like there probably are people who do, but I don't know that I can really advocate for that necessarily. I think that if I felt like a patient was still having bad withdrawal, that might be helped, then I might add on tizanidine as well. Something like 2 milligrams, every 4 hours as needed.
That's really helpful. I feel like in some ways we've talked some about treatment, we've talked about withdrawal. The thing that we haven't talked about, though, is probably the thing people most associate with xylazine, if you've been reading some of the throwaway journals or elsewhere, which is the wounds. And so I have so many questions about these wounds. Are they common? Is it something that's pathognomonic? Do we know why they occur? What do we know, Matt, about these wounds right now?
Yeah. So, people always like to make the argument of correlation and not causation, right? And so I think that's kind of where we are with what I'll call xylazine-associated wounds, right? In our area, we see a lot of patients with really devastating necrotic wounds. We think that the mechanism of action is multifactorial, right? As an alpha-2 agonist, you're going to get peripheral vasoconstriction first. People who use drugs often have skin picking behaviors that may cause a little bit of an open wound, or from repeated injection at the same site, you're going to get local trauma and get some necrosis there. And then again, because you have prolonged downtime, you can also have pressure necrosis. A lot of our patients, when they're in chaotic use, they're not focused on nutrition, right? And so they're malnourished, and that makes wound healing a lot more challenging. And then risk for superinfection. And even in one animal study, xylazine was found to be directly cytotoxic. And so I think there are a lot of different reasons that these wounds occur. Can we prove definitively? I think we're pretty close to causation. Again, I don't want to get into the argument of correlation and causation, right? But I think we're pretty close to causation, and the wounds tend to be necrotic. They are at risk for superinfection. They can go all the way down to bone, and there have even been cases of autoamputation because the infection goes so deep. And we actually took care of a patient here at Cooper whose lower arm fell off one day. And he came into the hospital with an exposed humerus, and it was really devastating. He wound up getting upper and lower extremity amputations. And some patients, even if they haven't necrosed down to bone, they've really destroyed tendon and muscle function, and they're left with a non-functional extremity. And so sometimes our surgeons will offer them amputation to get a prosthesis that's going to be a little bit more functional. One of my worries around that is that we actually don't, because we haven't been following patients longitudinally, we don't know what their physical rehabilitation potential looks like. But what our plastic surgeons are saying and our reconstructive surgeons are saying is that skin flaps don't take, skin grafts don't take, and any attempts surgically to kind of restore function just have not been successful. I haven't really seen any great papers that really describe this, but I talk with our surgeons a lot who are very mission aligned and want to take good care of our patients. And unfortunately, a lot of times they feel like the patients they're going to be, candidate for amputation. Now, in terms of the wound care itself, again, these wounds tend to be necrotic, sometimes with superinfection. And if we think that the limb is salvageable, and hopefully most of the time it is, we really advocate for minimal surgical intervention. So previous wound care guidelines were like, you have to debride down to healthy tissue. But what we found in a handful of cases is that surgical debridement tends to make these things worse, that you can't actually get to healthy tissue. And what you really need to do is cover them with a petroleum-based salve, sometimes including topical antibiotic, non-adhesive dressing, an ABD pad, and almost treating these patients like burn patients because these wounds ooze so much. They're losing a lot of fluid, they're losing a lot of protein, and they're already malnourished. So I am usually recommending daily multivitamins. We know that daily multivitamins don't really help people who eat food, but our patients are not eating food, and I don't think we're going to hurt anybody with a multivitamin. And then really nutritional supplementation, calorie supplementation, vitamins, and local wound care. If there are areas of eschar or dense necrosis, we will sometimes do chemical debridement with something like Dakins for a day or two, but really limiting it to that.
Matt, I have a question. I vaguely remember hearing something about a potential role for hyperbaric. Is that something that you guys are doing, or is that what are your thoughts on that?
So, Kate, that's a wonderful question. That was a question that I asked when we were kind of getting ready for this NIDA conference that we participated in. I was like, hey, has anybody thought about hyperbarics? And the resounding response was no. And I think the issues around that are multifactorial, right? Like it's already hard. The chambers are really busy, right? We still don't really know what the mechanism of action is here, and we don't know that hyperbaric oxygen will help patients. I think it's a really interesting question. And back when I was a fellow, I had to take a hyperbarics course. And we learned that they were using something called TOCM to look at kind of vascular supply to these non-healing wounds. Apparently, TOCMs have gone out of favor. And talking with one of my colleagues who does hyperbaric medicine, they're now using fluorescein microangiography to look at the vascular bed. And I think it would be for non-healing wounds to see if they're a candidate for hyperbaric oxygen. I don't even know how to get that, but I think it would be super interesting to look at that in our xylazine-associated wounds to see what those vascular beds look like and if they might be amenable. But to my knowledge, nobody's doing that.
I want to ask one more thing, because I don't feel like we yet talked about the geographical distribution of this, and I feel
Sure.
like that's one of the things that is like evolving so rapidly. Sort of in 2024, is this something that we think is fairly widespread, or is it still mostly concentrated in the Northeast?
Oh, the forensic data suggests that this is spread all the way across to the West. And I was fortunate enough to be a part of a panel discussion at Tox meeting last year. And shortly after I gave my talk, somebody from California reached out to me and was like, we just had our first xylazine-associated wound. Can I share your slides? And I'm like, yeah, of course, share my slides. Anybody, I don't feel like I have any great ownership over them. But yeah, I think we're going to see this across the country. It's just a matter of time.
Matt, let me give you a couple scenarios. You have a patient who presents after an overdose. They have this prolonged period of somnolence. They wake up. We try to get them engaged in treatment. They're not interested at that moment in time. You recognize they've got some evidence of these necrotic skin wounds, and they're looking to get out of the emergency department, and it's 2 a.m. You get a small window to make 1 or 2 recommendations around those wounds. What would you pick?
Great question. I would pick keep it clean, keep the moist areas moist, keep the dry areas dry, keep it covered with a non-adhesive dressing and an ABD pad and a loose wrap, usually an ACE wrap, and try not to inject in that site. That if the patient's going to continue to inject, they need to rotate their injecting sites. We know that a lot of patients will continue to inject into a wound once it develops. Or, if we're talking about harm reduction strategies, maybe trying to encourage the patient to use intranasally. Although I will say, anecdotally, some of our patients who do say that they only use intranasally are still getting these wounds. That would be my kind of approach to that patient.
I love it. 2 a.m. advice is what every emergency physician needs.
Yeah.
I want to thank you for joining us today. This was a wonderful but whirlwind, I feel like, overview around all things xylazine. I know I learned a lot, and so I'm sure our listeners learned a lot as well. We look forward to hopefully having you back again in the future when there's some more research out, maybe some guidelines out, or maybe even if we're lucky, we'll have sort of seen this wave of xylazine hopefully come and go someday. Until then, we appreciate your help, and our sites across Equal will certainly be looking to this to incorporate into their local care programs and care packets. Thank you.
Thanks for having me.